Hey everybody, it's Kay back again today with our ongoing saga question here of that 42-year-old male that develops retrosternal chest pressure associated with diaphoresis, dyspnea, and hypotension. The 12-lead ECG shows J-point elevation 2-3 AVF. We've had this now, today is the third time that we're revisiting this same case. Why? Because on the exam, it's very, very common to have an unfolding type of case study where there's several questions based on the very same case. So I kind of wanted to get your eyes used to looking at it. So the question now says, which coronary is the culprit coronary? And that's a term that they like to use a lot, especially when it comes to the coronary arteries. Which coronary is the culprit coronary? So we have some choices here. We have the left main coronary, is that the culprit? Right coronary artery, left circumflex coronary, or posterior descending coronary. So again, the ECG changes, the J-point elevation is in leads 2, 3, and AVF. What do you think? I mean, what wall of the heart do you think is affected? We already talked about that a couple of days ago. And now what coronary is the culprit coronary? Well, if you said right coronary artery, you are absolutely correct. It's the right coronary artery that is the culprit. So you have to be able to take a series of steps and say if the right coronary artery is having a bad day, everything it supplies is having a bad day. So therefore, that is why we see Brady's a lot in inferior wall MIs, because 55% of people get their sinus node supplied by the RCA. And a boatload, like 90% of the people with an inferior wall MI will also have AV nodal block. And we talked about that in a previous day's question. Yesterday, in fact, or the day before. So it's, again, part of this 4-part series on this one patient. The one thing I want to remind you, and this doesn't really have anything to do with the question itself, but keep in mind we're dealing here with a patient that has a right coronary artery issue, an inferior wall MI. So injury pattern is what we're seeing with that J-point elevation. So it really falls on us to also do a right-sided EKG, because we are looking here for ST segment elevation in V4R. ST segment elevation in V4R tells us that not only have we infarcted the inferior surface of the left ventricle, but we've infarcted the right ventricle as well. And it's important to know that because it kind of puts the writing on the wall for us as to what kind of problems we're going to face, like right-sided heart failure, for example. It also tells us about this patient's right coronary artery and the fact that that lesion is probably a very proximal lesion. So it feeds us a bunch of information about, patient outcomes, because patients have a tendency to do worse when we see ST segment elevation in V4R as well as the inferior leads. So I hope you enjoyed the question today. Head over to my website if you would like to check out what I have to offer in terms of courses. I do also want to give you the heads up that on August 6th, I'm doing the second of my series, my 12-lead series. It's absolutely free. It's like 1 hour. And this time we're going to be talking about bundle branch blocks and Brady-dependent and rate-dependent, tachy-dependent types of bundle branch blocks will be included. And like I said, it's free, so why not? It's at noon Central Daylight Time on August the 6th. So head over to khoppypresents.com. There'll be a pop-up that comes up if you are interested in registering. If not, please do stop over at my website and take a look at all the courses that I have to offer, as well as my membership community. Thanks so much for your time, guys, and have a wonderful day. Bye-bye.